So guys, today we're going to actually talk about one of the major pathogens of our actually entire body, and that is going to be your heart failures. And this is very, very important that we talk about in a very depth because one of the major cases or pathology that is actually that we want to talk about, or that has like a lot of like prevalence, is your heart failure. And I want to give some stats based on that. Like, you know, every year, like they have like about, I'm talking about the United States of America, every year they get like about like 550,000 new cases each year that's related to like your cardiac failures. And also the prevalence is about like 5.8 million that is happening in United States. And then the office visits regarding like your heart failures is about like 12 million visits annually, like every year. And usually like your heart failures are happens more with elderly people, like people who are aged like 65 and up, like especially male. So this is like one of the major concerns that we have, that we need to actually talk about this in a very detail, because this is one of the common diagnoses of hospitalized patient age 65 and older, right? So this is really important that we understand the good pathogenesis of like heart failure really well, really understand, and we'll talk about that in really well. But this is like really, really important that we understand this concept extremely well. All right. So now, so we're going to talk about, first we're going to define like what is heart failure. Okay, how do we classify it as a heart failure? Okay, so basically heart failure, when we're talking about heart failures, we talk about the heart failures are basically the heart as a pump. It's not able to propel the blood at a sufficient rate to meet the metabolic demands of your tissue. That's what usually heart failures, that's the definitions of heart failures. So giving you like some of the concept is, let's say if this is my, let's say this is my left atrium, and then let's make this as your pulmonary, sorry, this is your arteries, okay? So really what happens is that if somehow, like if the pressure is really high here, the ventricle filling pressure is really high, and the atria is not able to fill the blood here, okay? And what happens is that maybe due to the high filling pressure here, okay, so atria is not able to fill the blood, so your ejection fraction is, or your cardiac output is less, okay, and it's not meeting the metabolic demands of the tissue. That is called your cardiac output failure. We call them a low cardiac output failure, okay? So whenever there is if your heart is not able to pump the enough volume of blood, or stroke volume, to meet the metabolic demands of your tissue, that is why we call them as your cardiac failures, okay? And usually the cardiac failure can be caused by a lot of different things. Like there are a lot of different etiologies of why there is a cardiac failures, and we need to understand before we talk about the causes of the heart failure. Let's just quickly review the physiology or normal physiology of the cardiac failure, right? So remember, like whenever we talk about heart, we talk about the cardiac output is equal to your stroke volume times your heart rate. This is what normal is, right? And then remember, we can even say this as cardiac mean atrial pressure is equal to, I could even say this as let's say this is my systolic pressure, okay, systolic times your diastolic pressure, all right? That is I'm writing just down equations, and that's the blood pressure equations, right? Or I could even write down blood pressure is equal to cardiac output times TPR, which is a total peripheral resistance, or I can even say systemic vascular resistance, right? Now, whenever we talk about, remember, we're talking about the cardiac failure, right? This stroke volume has like multiple mechanisms. What determines your stroke volume? That's something we have to understand, right? And there are a couple of things that determines your stroke volume, right? What is the number one thing that is actually determines your stroke volumes? So whenever we talk about left or right heart, we have to understand the intrinsic like elastic properties of your ventricular myocardium. If we have to understand whether the ventricular myocardiums are itself is healthy or not. So we have to understand the intrinsic, okay, elastic, the properties of the ventricle myocardium. That's the number one thing we have to understand, right? Because if there's a myocytes, or if the loss of myocytes, or there is some kind of like coagulated necrosis are formed, then we have compromised the contractile tissues. So in that case, you're not able to eject the good stroke volume. Okay, so we have to understand first that one, and the other one is obviously your end diastolic volume, or we can simply say preload. And what is preload? We'll define that too. So preload is basically preload is basically means is that it's a passive process. Okay, whatever. If I make this as, let's say, if I make we'll just simply say let's say this is my and then let's say this is just making for understanding purpose. Okay, these are two beakers. Okay, so let's make sure this as, let's say this is my one atria and this is my ventricle. Okay, so what happens is that, and we make this a mitral valve here, look, and we're working as a pump, right? So what happens is that, look, whatever the volume comes passively without contractions of the atria, okay, whatever filling here, that causes stretch. That causes pre-stretch on this myocardium, okay, before the contraction. That is what preload is. And a preload is completely passive process, okay? And then, so before the contraction, whatever the volume that is accumulated on your ventricle, and that causes a little bit of pre-stretch, that is what preload is. And that also determines your stroke volume. Because remember, based on your Frank-Starling law, what did he say? Frank-Starling law say that, he says that if you're okay within the physiological limits, if you have, let's say, more preload, then obviously you're going to have more cardiac output. If you have a less preload, you're going to have a less cardiac output. Okay, and that's what it says, but within the physiological limits, right? So before the contraction, right? Now, and we can also compare this graph with length and your tension graph. Remember, if your length is stretch, right, then it can develop more tension, obviously within the physiological limit. So your Frank-Starling basically says that if you have a sufficient amount of preload, your heart is able to propel more cardiac output. Okay, that's what preload basically means based on the Frank-Starling law, and we cannot forget that too. And other one is obviously your afterload or resistance, because remember, if there's a lot of resistance. Okay, if there's, let's just make this as again heart, and if there's, let's say, a lot of resistance here, and if I make, and let's say this arteries are stiff here, right here, or maybe this valve is stenosis here, maybe it could be pulmonary valve, it could be aortic valve, if it's stenosis, or then what happens is that this ventricle has to actually contract in a higher pressure to actually open this valve, this narrowing valve. So because of that, that could lead into actual decrease in cardiac output. So because of that, we also have to understand that if there's higher resistance, then obviously it's going to have less cardiac output too. Okay, so we have to, and this all three combinations actually determines your stroke volumes. Okay, and then this one we can also talk about the and obviously this intrinsic property of the property we can talk about as contractibility of the heart. And contractibility of the heart is also very, very dependent on hormonal. If you give you epinephrine, that could be able to increase your cardiac output. Okay, so it's very hormonal dependent. These are the things that actually determines your stroke volumes, and we have to understand this really well. And then obviously your heart rate is based on your if heart rate has to do with the diastolic intervals, right? So basically, if you have tachycardia, let's say you have a very, very increased heart rate, that means what happens is your diastolic interval times decreases. So if because your heart rate is rapid increasing so fast, then if your diastolic interval time is less, then what happens? That tells you about the filling time of your ventricles, and your ventricles filling in a very short period of time. Then what happens? it would not able to fill properly, so obviously you're going to have a less cardiac output, right? So that's what the heart rate tells you about the diastolic interval times. And then obviously in normal conditions, if you increase your heart rate, you increase your cardiac output. But if you severely increase, pathologically increase in your heart rate, then that would actually decrease in your cardiac output. And then this cardiac output is very, very important, because this cardiac output tells you about like your mean atrial pressure, meaning like perfusion pressure for your systemic circulations. If you're talking about the left heart, if you're talking about the right heart, that is going to your pulmonary vasculatures. So we have to talk about that. But today, like, what we're going to do is we're going to basically we're going to focus on our left heart failure, because left heart failure is one of the most common etiologies that we get to see. And then next class we'll talk about the right heart failure as well. Okay, but today we're going to heavily focus on the left heart failure, because that's one of the most common the common cause of your heart failures. Okay, now these are some of the general concepts that I want to let you guys know. There's a good review as well. Okay, but now we're going to talk about etiologies of like your, let's say, left heart failure. And we also have to understand the concept of like a systolic dysfunctions and also diastolic dysfunction. And as we go, we'll talk about what that means also, right? Now, let's talk about remember I talked about your stroke volumes. Obviously, one of the important key features is that for your cardiac failures, okay, there are two things, okay? There's a concept of there's a high cardiac output failures and there's a low cardiac output failure. Today we're heavily going to focus on low cardiac output failure, not high cardiac output failure. Let me tell you what is high cardiac output failure also means, and then because it's less common, so I don't want to actually emphasize more on that. But high cardiac output, basically, high cardiac output failure basically means is that and usually you get to see that in a certain conditions, like for example, you get to see that in a like hyperthyroidism conditions, or maybe in a like beriberi, or maybe like AV fistula. These are some of the etiologies of the high cardiac output failure. Even severe anemia, you could see that. So what is the actually why they call high cardiac output failure is, let's say like normally your left ventricle, your right ventricle, it will propel how much blood? Like 5 liters per minute. That is your normal cardiac output, right? So sometimes like the metabolic demands of a tissue become so high, like for example hyperthyroidisms, right? The tissues is rapidly breaking down the ATPs, and you need a extra amount of oxygen supplies to that tissue, right? So for example case, let's say that tissue demands, let's say about, let's say the tissue demands is really high. Let's make this as a 10 liter per minute, okay? And then somehow what happens, so this is just like I'm giving examples, right? But our cardiac output, what happens is that, but then after that, what's going to happen is your tissue is going to produce, because tissue cares about whether they're receiving the oxygen and nutrients or not. Because if they are not receiving, they're obviously going to produce like lactic acid or this the carbon dioxide, and H plus, proton concentrations, adenosines, all that factors, right? And then obviously, and those are local metabolites, okay, and they're going to do a vasodilations on your total peripheral resistance, all right? And so what's going to happen is that this cardiac output, with that, what happens is that they will sort of like, what they do is, based on that, what happens is that your heart will try to compensate by increasing cardiac output to meet the metabolic demands. So maybe the heart will able to like throw or propel the blood maybe let's say 8 liters per minute. Okay, look, guess what happens? Heart normally is 5, but it is propelling 8 liters per minute, but still the tissue demands is like 10 liters per minute. So because of that, it's not able to meet the metabolic demands of the tissue. That's what we call this a high cardiac output failures. And usually like you get to see that in beriberi, like some of the conditions like beriberi, all right? Pregnancy too sometimes. This could be like pathological, this could be physiological too. And then there's AV fistula. Okay, because usually what happens, AV fistula is basically, what happens is that, sometimes like your atrial and venous, really what happens, maybe let's say some kind of injury happens, and then with the surgical repairs, what happens is that atrial and venous, they kind of like join together, okay? And because of that, there's a shunting happens. So your tissues are not getting like oxygen and nutrients. Because of that, there will be a high cardiac output failures. So these are like some of the conditions, even like severe anemia too. These all are like your high cardiac output failure, and these are like really like not very common, but I just want to let you know what high cardiac artery failures are also, okay? Now, but we're heavily going to focus on low cardiac artery failures, and that's what we need to focus on, because remember, with the low cardiac artery failures, right, basically what happens is that even if it's like there's something called systolic dysfunctions, all right, and then there's also called diastolic dysfunctions, all right. So in both the cases, whether it's a systolic dysfunction or diastolic dysfunction, they both are going to have a low cardiac output, okay. And we'll talk about what are the etiologies that actually causes your systolic dysfunctions. We'll talk about it too, right? But systolic basically means contractions, all right, and then obviously diastolic means relaxation sometimes. So there is some kind of relax. There is this is like your heart, it's not able to relax properly. That's why there will be going to be the problematics that will be created into that, okay. So, and as we talk, we'll talk about that too. But now when we go detail about the causes or etiologies of your left heart failure, remember we said like some of the conditions that actually causes your left heart failure, right? And those are, and usually like we can sometimes these heart failures have like from heart. There's a wide range of why there's the cardiovascular insults are there, but we can group these etiologies are in like three different things. One is called, let's make here, okay. One is going to be impaired contractibility, okay, and we'll talk about what does that mean. Remember, we're talking about the intrinsic health of that. And the other one we can even talk about like, okay, what are the causes of this one? And then the other one would be like you're gonna have a chronic afterload problems, all right, and then all the other ones will say that would be your diastolic feeling, or your impaired on diastolic feeling. Okay, these are like usually we can group these things into these are more common, right? And when there's impaired contractibility, what are we talking about? Whenever impaired contractibility is because let's just say this is my like one heart, correct? And then let's make this as a aorta, right? And this is the left side of the heart because that's what we're focusing on, right? So what happens is that let's say in here there is infractions happens, or like some kind of ischemic conditions happens, okay? So because of the transient ischemia, okay, because of that, what happens is that this is ischemic means that they're not able to receive like oxygens, okay. So these cells, when they're deprived from oxygen, they're not able to make ATP, right? And they will lose, and there's a loss of the myocytes could happen too, because that will be infection. But whenever they have this oxygen deprived cells, they were not able to work, so they lost this contractibility ability, right? So whenever they lost this contractibility ability, we call this as ischemic, and this is one of the major cause of like your low cardiac heart failure. So we say ischemic heart disease, right? And then usually the ischemic heart disease over the learner, what happens is that this will get infracted, okay, what is called MI. So we'll say myocardial infarctions happens, and usually with the myocardial infarction, really what happens is like with the time being, there is a coagulative necrosis will happen, right? And after like a couple of days, 1 or 3 days, like a lot of neutrophils will come and try to like clean off those bacteria and all that stuff. And then also later, like after 4 or 5 days, you'll see the macrophages also come there. And then later, this infracted tissues will be like healed or covered by scar tissues. And we'll talk about that when we talk about MI cases. But just let you hear some of the conditions that could give you. But guys, one more thing that I actually did not talk. Whenever we talk about heart failure, we have to understand this guy, which is a Laplace law, which basically says pressure is equal to 2H, which is the thickness over tension over radius. We need to understand this to understand the cardiac failures. All right. Now, that's a Laplace law, right? Now, and we'll talk about how do we use this too. So basically, these are some of the conditions of like ischemic heart disease, MI, that is actually going to compromise the contractile of the tissue. So obviously, if there's a problem with the contractile tissue, what's going to happen is that these guys will not able to propel the sufficient rate of cardiac output, right? Other one is like, let's say there is a there's a valvular problems. Let's say there's a mitral valve. There's a mitral regurgitation. If you're talking about, if it's a mitral regurgitation, what happens is that whenever, let's say aortic is fine, right? Whenever the mitral regurgitation, what's going to happen here is that, look, the blood volume, whenever the ventricle contracts, some of the blood will go to the atria, right? And then atria is that time what time? That time what is happening when a ventricle is contracting, the atria is going to diastolic, the atria is relaxing, and it is getting venous blood from your lungs, right? So it's accumulating here. So because of that, really what happens is that these guys, over the times, what's going to happen is that there is a lot of like volume overload, right? The volume overload. And whenever volume overload is going to happen, what's going to happen is eventually, because of volume overload, what's going to happen is that there will be dilated, these ventricles will get dilated, right? Meaning the radius will be bigger. Remember, the law even say your pressure is equal to what? 2ht over radius. So if your radius becomes high, then what's going to happen? There will be the pressure will go down, right? And because of the pressure is going down, obviously you're going to have a decrease in cardiac output, because remember the pressure tells you about how much it's going to propel, right? So so in this condition, what's going to happen is that you're going to have, it's going to have a dilations, right? So this is called dilated. This is a dilated ventricle, so dilated chambers, right? And obviously at the same time, there's a hypertrophy also occurs with ventricles, okay? But ventricles also go to hypertrophy, and this type of conditions this type of hypertrophy, we call them as a eccentric hypertrophy, which basically means is that because these get dilated, that means you're going to have if the ventricles get dilated, what's going to happen? There will be because of that, and then because it's working on the lots of the ventricle. What's going to happen is that the myocytes, there will be myocytes which get longer, okay? And then there will be thickness will occur because the ventricle is working like with a lot of the volume to push the blood out, right? So because of that, what is going to happen is there will be a longer myocytes, thickness of the ventricle wall, that's going to happen, right? Now, and then also because of the dilation, the sarcomere will be lengthier, okay? So because remember, if this is my normal, okay? If this is my normal, this is contractions will occur, but if I lengthen it and it's not able to like make like a lot of these stroke cross cycle bridges, it will not able to like generate pressure, tension to push the blood out. So that's what's happening here. And this kind of heart failures or this kind of hypertrophy, we call them eccentric hypertrophy. Just letting you know. And then usually those eccentric hypertrophy, you get to see that in your systolic dysfunctions, okay? And okay, let me write down this mitral regurgitations, right? I mean, one of the concepts we'll make is, let's say, volume overload. The volume overload, right? And the volume overload has to do with the mitral, maybe regurg, right? And then other one would be maybe like aortic regurgitation also can give you that. All right, now, and then obviously, let's say this ventricle pressure is higher here, okay? The ventricle pressure is higher because of these conditions, then later it's going to have a dilated cardiomyopathy too. So all these conditions that is going to actually compromise the impaired contractibility of the cells. So whenever there's an impaired contractibility of the cells, really what happens is that the ventricle myocardium, there will be ventricle myocardium would not able to actually propel the blood out. Like for example, remember, you can also say this Laplace's laws are these are what is tension, or you can say the ventricle stress is equal to, I can say, pressure times radius over your thickness, right? So remember, if there's a lot of blood volume, it's going to have a lot of tensions, right? If there's a radius is elongated, right? What's going to happen? There will be a lot of stress because your radius is directly proportional to the ventricle wall stress or ventricle tension, right? If a lot of volume is overloaded here, then there will be a lot of stress onto this wall of the ventricles, right? And then because of that, what's going to happen is that when the systole happens, when the contraction happens, they have to contract to that lots of volume of the waters, So because of that, it would not able to generate like enough pressures, okay? So generate enough pressure or enough, you do not able to have enough cardiac output, and you do not able to propel the sufficient rate of the cardiac output to meet the metabolic demands of your body tissue, right? And this is all result into your impaired contractibility, okay? Now, these are just some of them like systolic dysfunctions of that, right? Now, what about afterload? When we talk about afterload, look, what happens is that one of the conditions of like that could result into your left heart failure is like, look, let's say uncontrolled systemic hypertensions, one of them uncontrolled, right? So uncontrolled systemic hypertensions. This is the one of the conditions, okay? So remember what happens. If your hypertension has always been higher, right? If you're not able to control, that means that provide a lot of resistance. So over the long time, then what's going to happen is that your heart is going to fail, okay? That's why it's really, really important to actually regulate or maintain the patient's blood pressures, okay? Because this is a silent killer. Eventually, it can lead into a heart failure. So it's really important to maintain or regulate the patient's blood pressure really well, okay? Other one is, let's say maybe like aortic stenosis. Aortic stenosis, that could gives you I mean, other one is a correction, I don't know how to say this, but there's a like preductal correction of the aorta. Now look at all this, guys, but like basically even with that too, like anything that is actually put a lot of resistance into it, that's gonna actually get that can have actually you're going to have a cardiac output, low cardiac output, right? And usually like uncontrolled hypertension or aortic stenosis, usually this one usually happens because of, and this is usually because what happens is like, in this case, your ventricle has to work, contract over the higher pressure, right? So because of the higher pressure, really chronic pressure overload, what's going to happen is that that's going to result into obviously low cardiac output, and then obviously if it's low cardiac output, that means your system circulation is not going to get perfused, and then you're not meeting the metabolic demands of your tissue, right? Now, other thing here, impaired or diastolic feeling, which basically means is that there's some of the conditions, like for example, you have left ventricular hypertrophy, okay, hypertrophy. So left ventricular hypertrophy, maybe let's say because of this, let's say aortic stenosis, because if the high pressure is going to happen, what's going to happen? Because of the aortic stenosis, let's say the valvular problems, your ventricle is going to, first what's going to happen? Remember, Laplace law, what does it say? Pressure is equal to HT over radius, right? Basically, look, whenever there's a lot of high pressure, what's going to happen? It's going to develop thickness and then tension, right? But whenever those ventricles go hypertrophy because of the aortic stenosis, because of pressure overload, what's going to happen is that what is going to happen? Your wall will get thickness. You'll get a lot of thicker, and then it's not going to get dilated first. First, it's going to get hypertrophy. And what kind of hypertrophy? This is called concentric hypertrophy. Okay, it's a concentric hypertrophy, which basically means is that obviously the wall are going to get thickness, but really what happens is that, let's say if this is my normal, okay, because of the hypertrophy, okay, what's going to happen is that because of the hypertrophy, pressure overload and all that kind of stuff, these guys, these myocytes will get actually shorter, like become more narrow actually, okay, and then eventually they will get dilated too. But first with this one, it will become like narrower, and it will not able to actually propel the blood out, right? Now, and at the same time, there's a lot of stress on your ventricle wall too, okay, and then that will cause your left ventricle hypertrophy. And whenever there's a left ventricle hypertrophy, what's going to happen is that, look, whenever the ventricle is very hypertrophied, whenever there's a pressure comes in right here, right? Look, whenever the atria has to contract, at the higher pressure of the ventricle, okay? Because it has to contract the higher pressure, it produces sound, and there is a S4 sound that's produces. But if you talk about like here, if I quickly talk about 3 sound here, let's say dilated cardiac myopathy, right? So a lot of blood volume is overloaded here, right? So whenever let's say blood volume, whenever there is the mitral valve opens here, whenever there is the rapid blood, whatever blood accumulated from your atria, it comes into you and splashes on the blood, that will produce S3 sound in this case, right? So usually, like what I'm trying to say is like, usually this case is called systolic dysfunction, right? Usually systolic dysfunction, there's S3 sounds are produced because there's volume overload, and then whatever atria is also receiving the venous return from the lungs, right? And then that splashes onto the ventricle, that will be able to produce S3 sound, okay? But this one is like because of volume overload. But here, ventricular hypertrophy, maybe because of aortic stenosis, what happens is that there's a more pressure in here. There's on your ventricle. Because there's more pressure, atria has to contract over the ventricular pressure. Because of that, they'll produce like a S4 sound. Okay, just wanted to let you know that. And not only that, like other thing it could cause is because of, okay, one other thing is like you will have, let's say, some kind of like fibrosis or deposit here. Like one of the key one is this. It's called amyloidosis, which basically means like some kind of amyloid proteins get deposited into it. Like there is a ATTR amyloidosis, okay? And whenever this gets deposited into here, your tissue becomes what? Very, very fibrotic. Okay, when it becomes fibrotic, it becomes restrictive. It would not able to, whenever the blood will come here, it would not able to like stretch out, okay? So if you're not going to stretch out, this becomes narrow, right? So you're not able to take the good amount of the blood volume, okay? So if you're not going to get the a good end-diastolic volume, so there will be decrease in, let's say, end-diastolic volume, right? If you're going to have decrease in end-diastolic volume, you're going to have decrease in cardiac output, right? So if this is the case, then look, you're going to have this because the ventricle is not able to relax properly, right? That's why it's not able to fill. So this is called your diastolic dysfunctions, okay? Remember, with the both systolic dysfunction and diastolic functions, in your systolic dysfunction, let me write systolic dysfunction, you have a low end-diastolic volume. Okay, sorry, you have a high end-diastolic volume, because remember, this is high end-diastolic volume, right? Your high end-diastolic volume, and then you have a high end-diastolic pressure. But if you look at the diastolic dysfunctions, you have a low end-diastolic volume. Volume is going to be low, but you're going to have a high end-diastolic pressure. This is one difference that you have to understand. Again, let me repeat it one more time because this is worthy of repeating. With your diastolic dysfunction, you're always going to have a decrease in end-diastolic volume. But in your systolic dysfunction, you're going to have increase in end-diastolic volume, plus you are going to have increase in end-diastolic pressure as well. In your distal dysfunction, there will be increase in end-diastolic pressure, but there will be decrease in end-diastolic volume. Okay, that's one of the things you have to understand. Now, and then not only this, like for example, like some of the virus. What are those virus? Like for example, some of the virus also could give like a lot of this cardiomyopathy problem, especially like for your impaired contractility of your systolic dysfunction. Like for example, if I give you like some like anti-arrhythmia drugs, for example, like if I give you beta blockers, like these are called class 2 beta blockers, okay, and some of the drugs are called propranolol. So propranolol is one of the common one, and then SC2. So propranolol, acetobolol drugs, these are common drugs, and these ones are class 2 beta blocker drugs, right? And what happens is that sometimes what these guys do is that this play a role of like negative inotropic drugs. Like if you overdose of giving that's going to suppress to excite the cells so much, you're going to have a decrease in cardiac output, right? That's going to cause heart failure too. There are also like, for example, like sodium channel blockers, obviously your L-type calcium channel blocker, like your L-type, also this is L-type, obviously anti-arrhythmia drugs like L-type calcium channel blocker. And what are some of the drugs names? One is called your verapamil. Okay, this is the one. So the verapamil is like, what happens is that if you go overdose of these verapamil drugs, what's going to happen is it could actually even cause the AV block. Okay, because of the AV block, really what happens is that you're going to that would also cause your systolic dysfunctions. All right, and then because that's going to actually create a problem with the contractile tissues. That is one of the things of another problem is the systolic dysfunction. Right. So look. The impaired contractility, look, all this condition right now I talk about, this is all systemic right here. All this, even the beta blockers, all this are systemic, okay? These all are systemic dysfunctions. And also like some of the drug related, like there's a drug called like cocaine or even alcohol or your doxorubicin. This is it's called doxorubicin. This is also like one of the drugs related problems. That could also actually compromise the contractile tissues, contractiles of the ventricle myocardium, and that could actually also cause systolic dysfunctions. Okay, and then one of the other thing is like if you want to remember, there's some of the virus. There's one of the viruses called viral myocarditis, which is a Coxsackie virus B, like Coxsackie virus B. It's called Coxsackie. I don't know how to spell this, but virus B or some like enter a virus drug, this also can actually compromise the ventricle myocardium cells, because they can go at the myocytes, they can send myocytes. And then remember, there's the virus, they can create hosts, and then can actually cause problematic for the cells. That can also compromise with your contractibility tissues or the intrinsic health of the heart, and that will obviously going to create problems for your health. Like parasitic infections, like Chiga's disease, that's also going to create problems. Okay, now, so far, I've been talking about what are and these all conditions that so far I talked, these from up to here, let's just say all these things, these are going to be systolic dysfunction, right? The chronic afterload and impaired diastolic feelings like left ventricle hypertrophy. One is, and the restricted diseases like amyloid fibrosis getting deposited into there, like ATTR, that can, or even guys, is it cardiac tamponade, right? Cardiac tamponade, what is cardiac tamponade? Cardiac tamponade is one of the conditions, because what happens is that whenever the fluid accumulates on your pericardial cavity, we call them hydropericardium, or we call them pericardium effusions, and that pericardial effusions become so much that when they compress your heart, and then it compromises your heart, we call them as a cardiac tamponade, okay? And then cardiac tamponade is going to be fibrosis, right? It's not going to allow the ventricle to relax, and then that's going to compromise your diastolic feeling, okay? And that's going to cause your diastolic dysfunctions. So this is very important that you understand the etiologies of diastolic dysfunctions, okay? So all these things, so far I've been talking about diastolic dysfunctions and systolic dysfunctions, okay? Well, let me quickly, whatever I talked about it, let me quickly compare systolic diastolic in a pressure volume loop, and then we'll talk about how that's going to look like, okay? So now, okay, so one of the things usually what happens is that, look, if I make this pressure volume loop right here, right? Pressure volume loop, and obviously it's going to be pressure, and this is going to be let's say, this is going to be volume, right? And we'll make usually this as a normal. So usually, let's say there's 140 ml of the blood on this end as the volume, and this is V, right? And usually you're able to propel let's say 60 ml would be your systolic volume, right? And then if I make this, okay, let's say this is my normal, okay? So if this is my normal. So if I'm on my normal, so obviously this mitral valve opens here, mitral valve opens here, mitral valve closes here, isolated valve contracts here, AD valve opens here, AD valve closes here, right? If we're talking about the left ventricle, these are systolic volume too. Now, basically we have to understand some of the etiology of systolic, and then first we have to understand normal. So this is called my stroke volume, right? Stroke volume is basically your end diastolic minus and systolic volume, right? So the ventricles propelling, each ventricles from the right and left ventricles propelling its ventricles, okay, how much blood is popping out from the propelling from the ventricle, those are called stroke volumes, right? So if it's 140 minus, what is it, 60 ml, right? What is that going to give me? That's going to give me 80 ml of the blood, right? Does it give me 80 ml of the blood, right? That's going to be my stroke volume for this case, right? Now, what is my ejection fraction for this one? So ejection fraction basically means is that how much the blood, we're basically measuring the contractible tissues of the fractions of end diastolic volume ejected from the ventricle during each systolic contraction. That is what ejection fraction is, right? So if I do my stroke volume divided by end diastolic volume, that's going to give you what? 140 over 80, right? So this is going to give what? It should be 57%, right? And look, guys, if we come out with 57%, that is normal, because remember, ejection fraction that is happening from 55 to let's say 75%, we call it as a normal ejection fractions. And some of the people who exercise, some of the people who exercise, the ejection fraction could go up to 85 or 90, and that usually is also normal. So what is the stroke volume? Sorry, this is not going to be the stroke. This is going to be 80 over 140. So that's what it should give you, right? I think something like that. Yeah, it should be the other way around. So that should be about 57%. Now, this is normal, right? Now, if I let's say for example, I have a systolic function. Systolic function is maybe there's impact contractibly, one of the ischemic heart conditions. So really, what happens is that this graph right here, make this. Okay, it'll go a little bit up. Let's say it'll go up from here. It'll go a little bit up. The pressure, look, the pressure is rising here, okay? Remember, in the both condition, if it's systolic, the pressure will always rise. So there's a pressure rise here. It'll go up, right? Like that. And then you will back and make it like this. Okay? So now, whatever the conditions, we'll say this is going to be like, let's say, my 80 ml of the blood. Okay? So now, if I do stroke volumes, 140 minus 80, right? So what is that again? What is that going to give me? 140 minus 80. So it should give me 60 ml of the blood, right? Now, if my 60 ml of the blood, and if I find my ejection fraction, what is that going to give me? Ejection fractions. My ejection fraction for this one is obviously going to be 60 ml, right, over, right? Sorry, let's make this as, this go a little bit upper, right? So the pressure went, but the volume didn't change. So that would be probably going to be 140. So if I do that, so that will give me about like 42.8%. So now this is got, so that is the ejection fraction is low, and ejection fraction is always low when it comes to systolic dysfunctions. That's something that we have to understand that really well, because whenever there's a systolic function that you were talking about, the contractions, because this ejection fraction tells you about the systole, and diastolic stroke volumes over end-diastolic volume during its systole. That's what ejection fraction tells you, right? Because of that, that actually represents your systolic function. So if there is less than 55%, then we usually say that there's a compromise with the contraction ability of your ventricle myocardium, right? But with the like end-diastolic volume, but for example, if you are diastolic dysfunction, right? So usually with this diastolic volume is the pressure goes up right here, like pressure goes up, like a little bit goes up maybe, okay, in the both the condition pressure goes up, right? But really what happens is that, it's not much will be changes. Like this could be probably, let's say, we'll make this as, let's say, this is 60, probably, let's make this 62 or something, right? So if I do this, 140 minus 62, right, divided by, if I do that, what is that going to give me? 140 minus 62, that's going to give me 78, right? Now, if I do 140 divided by 78, so now, if I do that, so what's going to happen is like, this is going to get 78. That 70 ml is my stroke volume, right? So if I do 70 ml of the stroke volume divided by end-diastolic, which is 142, you should be able to give me 55 something percent, right? So look, when it comes to diastolic dysfunctions, your ejection fraction is usually like preserved. Basically means is that your ejection fraction come out to be normal range, okay? When it comes to diastolic dysfunction, that is very, very key concept. Ejection fraction is usually normal when it comes to diastolic dysfunction, but ejection fraction is always low when it comes to systolic dysfunction. And this is something that I wanted to let you guys know about this too, right? Now, it's very, very important that you understand this extremely well about how this is happening here, okay? Now, talked about like, give you a kind of like general concept about like what is systolic, what is diastolic dysfunction, and also like what the etiology or what the causes that could actually give into like your diastolic or systolic function. But in both the cases, there will be low cardiac output. That's something that you have to understand here, right? Now, let's talk about the more detail about like what are the symptoms and signs and symptoms you could see from your heart. Okay. Now, remember, guys, always remember the Laplace's law. Okay, because Laplace is important law because that tells you exactly how your ventricles are working and all that. So if we quickly talk about this, right? So let's make this here as my heart here. This is going to be mine. Okay, let's make this actually bigger heart. So all right. And then we'll make this as my pulmonary artery. This is going to be a pulmonary artery here. There's going to be a pulmonary artery here too. Guys, this is going to be a pulmonary artery, okay? And then I'm going to Actually, you know what? Yeah, this is going to be pulmonary. It's very important because I'm going to make a lungs here. All right, and then I'm going to make another lungs here too. Okay, this is very important. So these are just like pulmonary artery bringing the blood into pulmonary artery being the two types of lungs. We have two lungs, right? So it's just like made a little bigger lungs. And let's just talk about, and then I'm going to make this as, what is going to happen is, let's make this as my, obviously this is my arteries, right? Aorta. And then we're going to talk about, okay, this is going to supply to, let's make this as like your GI. Okay. And then obviously I'm going to make, it's going to supply you, let's say kidney is very important. Kidney is here. All right. I'm just writing it down for the, and then obviously I'm going to make, let's say, skeletal muscles. Skeletals, and then we'll make another one. And then we'll make this one as a skin too. All right. Now, and then after that, obviously, then what's going to happen is the vein, right? There's going to be venules and the veins. All this come together, right? And then this will and then drain into here, right? Now, and obviously let me just make this quickly too. There's going to be a superior vena cava right here. All right, and then now I have to draw one more thing, and which is going to be, I'm going to make this one here. All right, and then let's just make this as a, okay, this is my brain, all right? And then this is my brain. And then obviously from the brain too, there's going to be inferior vena cava. Obviously you're going to have a, let's say this is a, and then this is going to be a, also, let's say internal jugular vein too, okay? And then from draining into your superior vena cava there right here. Now, talked about this. I had to do this, and this is the lungs here, right? Now, guys, it's very, very important that we understand this concept really well. And now let's make this as a, let's say capillaries right here. So broken of the capillaries, and then, you know, for like understanding purpose, like, you know, this is not like, you know, this is just for the understanding thing, not anatomically like correct, okay? So we'll make this as, like, let's say we make this as a, like one, this is also alveoli, okay? Like, this is a lungs alveoli, and this one you can think about this one as like, let's say bronchi, all right? And the same thing here too, guys. All right, and let's say I'm making this as like, you know, all right, now, just for the understanding purpose, all right, and this is going to be capillaries, all right, now, after that, obviously from here, what's going to happen is that, let's make this a little differently, okay, what's going to happen is that you're taking the blood out, and then you're draining into that, this is my pulmonary vein, all right, now, and from here too, what is this? Coming here, and then from here what's going to happen is that obviously you're taking the blood, and then think about this one is actually going to the, now from here this is going to drain into your left atrium, okay, pulmonary veins. Now, okay, now the concept here you have to understand really well. Obviously this is going to be my valve right here, and this is going to be bicuspid valve. We're talking about the left heart, all right? Now this is going to be a left heart, right? And obviously this is going to be my aortic valve right here, because we're focusing on the left heart right now. Now, and this is our systemic circulations. It's very important, right? Now, guys, let's talk about what is going to happen here. Is that it could be any conditions, like as we talked about, because we're talking about the, right now we're going to talk about systolic dysfunctions, okay? So it could be maybe there's a volume overload, okay? It could be there's a volume overload, or let's say there is a mitral regurgitations or aortic regurgitations, okay? Whatever it is, really what is happening is that in the ventricles, look, what is happening is that there's an overload of the fluid here. If it's overload of the fluid, really what is going to happen is that, look, if there's overload of the fluid here, what's going to happen? First, is going to happen is that this is going to get dilated, right? So remember, that means if it's going to get dilated, there's going to be a lot of stress on this ventricle wall, right? Then the lot of stress is going to, so the radius is bigger. Whenever radius is bigger, what's going to happen to the pressure, right? The pressure is going to decrease, right? Correct? So because your radius is, based on the Laplace law, it's a radius is increases because the dilated, the pressure is going to be what? Pressure is going to fall down, right? It's inversely proportional to one another. But there will be a lot of tensions on the ventricle wall, right? So that's all dilated. And then whatever the volume of the blood is, the ventricle start to contract onto that. So contract onto what's going to happen is that, what's going to happen with that is, with the contraction, what's going to happen is this. There will be thickness, all right? There will be thickness, and there will be tension on the wall of the stress. But because there's so much of, like, think about it as like there's lots of, in a big, let's say in a big bowl there's a blood, let's say in a big bucket you have lots of water, and if you try to squeeze it, it's not going to create a lot of pressure, it's not going to propel the blood out, right? That's what is happening here. Or one of the important things you can understand is maybe there's infected cells here. Like intrinsic, there is the elastic properties of this myocardium cells is compromised, okay? Because of this, or maybe there is some kind of the virus is there, right? Or I mean, let's stick with something like coronary artery disease, like, let's say coronary artery disease, like, the myocardial infection is there, or ischemic conditions there. So this cell is infected, this myocardium, there's a loss of myocytes there. If there's a loss of myocytes, obviously this cells is not going to what? It's not going to able to work. Like, it's not going to able to generate enough force to actually propel the sufficient rate of the cardiac output to meet the metabolic demands of all this systemic circulation, right? So now, when that happens, so like let's say, when this happens, there will be from here, there's a less blood is going out, right? So less cardiac output is going out. So decrease in cardiac output, right? So there is a decrease in cardiac output. This decrease in cardiac output going to the systemic circulation, correct? Now, when there's a decrease in cardiac output, what is going to happen is, there's also the volume left over here. Remember if you remember pressure volume loop, let's say, like, if this is my normal from here, and then if you make it, let's make this one, right? This is going to be slightly rise on here, okay? If this is my normal, right? With this guy, what happens is that pressure went down, pressure went up, like here, right? Like this, right? And then all the way went up, and then you have decrease on this one. So when you have this, there's a less cardiac output, right? Look, this one is 140. Let's say this one is what? 140. Let's make this as a 60 here, and then we made this 140, right? So 140 minus 60 ml, obviously. So that would give you stroke volumes of 80 ml of the blood, correct? Now, your ejection fraction, we said, was you do stroke volume divided by your end diastolic volume, and you was able to give what 57%, right? Now, for the normal, this is normal, right? Now, with this, the pressure went up, okay, the volume was not changing. So really what happens is that, in this case, if you look at this, my end diastolic volume in the normal is about 60 ml of the blood, which is end systolic volume, okay? Now, this is answer. But what is happening with my end systolic volumes when my heart was failing, or let's say there is a heart is failing, my end systolic volume went up. It increases in end systolic volume. You see what I mean? So because of increase in end systolic volume, my whole end diastolic volume is also increased, right? So because of that, wherever the blood is coming out from here, what is going to happen? There will be increase in end systolic volume, correct? Now, end diastolic volume, which means your left ventricular end diastolic volume will go up, which means your left ventricular diastolic pressure is also rise up here, correct? So now, there is lots of blood already accumulated, and then that time, what is happening here is that your atria is relaxing, and then what is atria is relaxing and receiving all the blood from the venous side, right? This is from, let's say, this is from your venous side, right? And this is also accumulating, this all blood was accumulating there, because remember, your right heart is keep bringing the blood to the lungs, right? And then lungs is keep giving, the venous return is happening, and lungs keep coming, the blood is, those atria is relaxing here, just like working as like sort of like a tank, so just receiving the blood, right? And there's already less cardiac output going on, there's a lot of volume is already accumulated here. So your end diastolic volume, left ventricular end diastolic volume, is pathologically higher than normal end diastolic volume, right? Because there is it wasn't able to propel enough cardiac output. Because of that, you have a high amount of end systolic volume. So you have increase in end systolic volume, which leads into increase in end diastolic volume, which means there's increase in end diastolic pressure here. So because of that, really what happens is that in the second round, what happens is that now, whenever the mitral valve opens up, there is a volume already accumulated here. Because of that pressure, because of this, what's going to happen is that whatever the passive filling, the pressure, what happens? The pressure will try to come in, right? So when the blood comes in, and on top of that, there's already a lot of blood accumulated here, that's going to actually splash the blood, so that blood will vibrate, right? And because of that, they'll produce sound, actually, which is called S3 sound, right? Now, that's the thing. Now atria has to contract. Already there is a end systolic volume. I mean, the left ventricular diastolic volume is really high, and then there's also end systolic. End diastolic volume is high, which means that the end diastolic pressure is also very high. So when the atria is trying to propel or contracting, on top of this, the pressure, what's going to happen is there's a back pressure will happen. So there's a back pressure happening because you cannot push the more blood because there's a lot more blood is accumulated here, right? So what's going to happen is that there's a back pressure happens. So when the back pressure happens, the blood that is accumulated in the atria, it'll go back to this pulmonary veins, and this is going to left. This is left side. It's a left backward. Left. We call this a left backward failures, and then there is a less blood is going to the system circulations. So we call the left forward failure. Okay, so this is the left is going forward because it's supposed to go to forward, right? So that's left forward failures. Now, what is the interesting thing is that, look, whenever there's a back pressure is happening here, right? So what is it going? It's going to go back. But look, luckily what happens, the pulmonary veins, they're thin wall, okay, but still the fluid is accumulating. The pressure on the pulmonary veins also goes up. Usually it's like 5 to 6 millimeters of mercury, right? But here it will go really high. So, but luckily what happens is because this was a thin wall, or actually they are thicker than your capillaries, your pulmonary capillary beds or any capillaries. So because of that, the blood is not going to ooze out from the veins, okay? And they also normally they are more compliant, all right? So veins, but because of the pressure, what's going to happen is, because remember, the pressure always high to low. So the pressure will keep coming down. And remember, the ventricle from the right side of the heart, right? This is my pulmonary artery, right? So look, pulmonary artery is bringing the blood from the right side of the heart and bring it to the lungs. Okay, both the lungs, right? Keep bringing that, and then from here there's a back pressure is happening. So the blood is coming from this way, and then also blood is going backward. So there's blood coming from forward here and coming backward. So because of the blood coming from backward from right side, the blood is coming forward, and then from the point where the pressure is coming backward. So the fluid is coming backward here. So because of that, really what happens when you get the capillaries, there will be increase in hydrostatic pressure here. There's a lot of fluid will be, and a lot of fluid start oozing out, like it will coming out, right? A lot of fluid start coming out from these pulmonary capillary beds. Okay, from there, a lot of fluids. So there will be increase in hydrostatic pressures on here. So whenever there's increase in hydrostatic, lots of hydrostatic, usually it can go up to like, let's say 20 millimeters of mercury of the pressure. So whenever there is there, so there's lots of hydrostatic pressure, there's gonna, all this fluid can start coming out, and they'll go and then they'll kind of like accumulate onto your interstitium. And this is called edema. Okay, but this is called pulmonary edema because now all this fluid is accumulating on the interstitium of the edema. Okay. Now this lungs has become congested. Same thing is happening on this side of the lungs too, right? Like a lot of this fluid is accumulating down here, right? And really what happens is that around down here, like this is what happens. And also around down here, what happens is that whenever a lot of fluid is accumulating here, pulmonary edema, there's some reflex. They're called juxta capillary reflex. Okay, the J-mediated cells. And what these guys do is, the J-mediated cells are based on the fluid accumulated there, right? What they do is they stimulate and then they'll send a sensory nerve fibers to actually vagus nerve. And what vagus nerve does? Vagal will block the efferent fibers, and because of that, what's going to happen is that these people have rapid breathing, rapid shallow breathing. Okay, and then the heart failure patient, and because of that. Because of this, there's a lot of fluids accumulated here. That means what's going to happen is that your lung become edematous, which means lots of fluid. That means the lungs become heavy. Okay, so heavy. So because of that, these guys would not able to breathe properly. Okay, so there is a conditions which whenever because of lots of fluid accumulated on this interstitial pulmonary edema, or these lungs become congested. What happens is that the people who have this kind of condition, they will have difficulty breathing. Okay, they're usually because breathing is your unconscious process, right? But this one has to. But because of that, these guys will have this condition called dyspnea. You will see a dyspnea on this patient. This dyspnea, okay, and then dyspnea. So the reduced blood flow to the lungs, okay, and then Also, what happens is that now, remember how we do inspiration is like, look, there's a contractions of your diaphragm muscles, okay, and then the diaphragm muscle, when the diaphragm muscle goes down, and they'll open the thoracic cavity, right, and then there will be much more higher negative pressure was generated into your alveoli, which is going to be -1 or so, and then the air will come in, right? But this one, really what happens is already lots of fluid accumulated here. That means there has to be like extra effort you have to put it in there, okay? Whenever there's extra effort you put it into there, you become like tired and weak also, okay? And then whenever and because of the reduced blood flow to the system, because a lot of fluid is accumulated, really what happens is that their nearby cells or capillaries, they will start producing like a lot of these protein concentrations or like H+, okay? Because of that, that would also contribute, lactic acid will be built up, that would also contribute to this pulmonary congestions, okay? Now, so these people, like with the dyspnea, like, they will have this dyspnea on exertion. That's what will happen, right? And then because of pulmonary edema, and then what happens is that as time buys, sometimes also what happens is this fluid that will become so much, what happens is they started going to not only the interstitium, it also goes in the alveoli, okay, and alveoli. And really what happens is because this pulmonary edema becomes so much, really what happens is the blood vessels down here get compromised, and some of the blood like red cells also comes out, and then they will even go to like, this alveoli, okay. And look, now alveoli becomes edematous. That means you have now not only the pulmonary edema, you have alveolar edema too, right? There's very, very problems. And whenever this alveolar edema, what's going to happen is that they will rupture some of the cells down here. And then remember, alveolar has like those dust cells, like fixed macrophages. They'll come up, and then they'll try to gobble up those red blood cells. Okay, whenever they eat the red blood cells, what comes out from there is something called the hemoglobin, right? The hemoglobin becomes hemosiderin. So there is the macrophages. So if you look at the microscope, what you're going to see is like this hemosiderin laden the macrophage. Okay, this is hemosiderin laden macrophages, and which represent the heart failure cells. Okay, now this is also you get to see in your microscope. Now, not only this, what also happens is that what is other thing is that happen, sometimes this edema becomes so big, what is going to happen is that now, with these people, look, they like to be in a like upright positions, okay, they like to say, because the reason why is because when you're upright position, what is going to happen is that your gravity is pulling the blood, right? So venous return decreases when you're in upright position because your gravity is pulling the blood down. But usually what is happening is that whenever there is in supine positions, whenever they actually lie flat, what happens is that venous return increases, right? Because all the blood levels are. Because of that, all the blood from the intravascular compartments, from the lower extremities, from the GI system, all of this will go up, right? When they will go up, there will be the more fluid get accumulated into here in your interstitium, right? So because of that, these guys will have these conditions called orthopnea, okay? So which basically is that this gets worsens as the venous return increases, and they will have to have a difficulty like difficulty actually breathing, okay? So so this is also very common. You get to see with people with this edema problem. So this one is dyspnea and orthopnea. This is called orthopnea, and that is because of that. And this gets better. Orthopnea gets better if you sit in upright positions, okay? If you stand. But if you lay down and sleep, then this can cause huge problems. That's the reason why, sometimes people with heart failure, it's important for them to actually put like 5 or 6 pillows on top of them, so that way this doesn't happen. And there are also called there are another conditions called PND, which it basically means is the proximal, okay, pronoctural dyspnea. What does this mean? What does this mean is as I said, what is going to happen here with these guys is that what is going to happen is they will, as when they were sleeping, they lost the breathlessness, okay, they lose the breath, okay. So whenever they lose the breath, really what happens is that because the venous return increases from the lower part of the body extremities, it all went, right? So from the your lower part of the body is all the venous artery increases, right? So sometimes like what happens with these sleeping patterns is that they wakens from like 2 to 3 hours after retiring to the bed, okay? They suddenly wake up to catch a breath, okay? So suddenly wake up to catch a breath, and that is what PND means, okay? This apnea, we call them as like more like a labored breathing, okay? But whenever lying in the flat, like they have to do like they have to do so much of like labored breathing, and because of that we call them as arrhythmia while lying flat, okay? So the only because of this is that the reason why that happens is because of redistributions of your blood from the lower extremity parties or your systemic circulation to back to the heart, your heart. That's the reason why you get arrhythmia, you get dyspnea, and also the PND. As I said, like you're getting up 2 or 3 times to actually catch a breath, okay? And because obviously this is more like this usually happens more like in advanced like cardiac failures, and this is with this type of breathing sometimes we call them like Shane, it's like CHE, like Shane stroke breathing. Like what happens with this guys is like this advanced cardiac, you can see this, like really what happens, like there's apnea, there's no breathing, and slowly they started breathing, and it's going, the tidal volume increases, goes up, and then after that it slowly comes down again. The breathing kind of looks like, and there's apnea, so it kind of looks like that with the advanced cardiac failure. This is called Shane stroke breathing, okay? So usually with this type of patient you get to see that too. And then sometimes really what happens is that there's a alveoli right here, right? So there's alveoli, and then you're going to have alveolar edema too. That's going to actually compromise your gas exchange and so too, right? And then not only that, like sometimes really what happens is the fluid becomes so much. Really what happens is that they will go to the bronchi right here. That's what the edema is here, the bronchi. And then what happens is that they will also like sometimes like the bronchi, because of fluid, the fluid is accumulated there. They rupture the engorged bronchi veins, and if they rupture the engorged bronchi veins, what's going to happen is hemoptysis will occur, which means that you're going to start coughing up blood. That's what usually happens, right? And not only that, like if the edematous is they have this if there's a bronchial edema, that because a lot of fluid accumulates, what's going to happen is that you'll get like something called like very, very dry cough or nocturnal cough too, because now all the edema is actually fluid is compromising your bronchi, and also and then you get obviously dry cough or nocturnal cough. Another thing is like one of the most important factor also you get to see is that if the fluid is accumulating in the bronchioles, what's going to happen is that whenever you do expirations, because you have to whenever you expire, the air comes out, right? And it's a passive process, right? Whenever in expiration the air is coming out, because normally what happens is this airways become smaller during your expiration. So because of the edematous, what happens is that even further compromise the airways. So because of that, when the air comes out from there, it actually makes it some kind of like wheezing sound. And this kind of sound is called cardiac wheezing. And this has to do with the cardiac wheezing. It's not because of asthma, it's because of your cardiac failures. This is the one thing that you get to see with this kind of patient, okay? Now, there's some of the things like also like you have to like understand is like sometimes like during like especially auscultation finding, sometimes what happens is that I just talked about expiration, right? That you see cardiac wheezing. But during inspiration, one thing that you have to understand during inspiration, what happens is that the small airways during inspirations, because there are small airways right here, like here, look at this. So what happens is this small airways, what happens, these air pockets, what happens is that these guys were closed or kind of like blocked because of like the edema, okay? So they're closed up. So because sometimes we take the air in, what happens is that these guys will pop open. This is called popping open. It's called popping open, okay? So it's called popping open of the small airways, and this popping opens, we call them as rails, or like the pulmonary rails, or the pulmonary rails that are found with the cardiac failures, rails or crepitus on the upper part of your lungs, because when the inspirations, these air pockets, I guess my ears, they open up, okay? And these are popping open. And you should know about this condition too, okay? Now, quickly, I just talked about it. And as this condition is happening, the ventricle failure that's resulting in pulmonary congestions, and which can give you a pulmonary edema, that can give you alveolar edema too. Even we talk about you can have a dry cough, like in some of the clinical symptoms of dyspnea, you'll definitely see this one, right? There's a labored breathing. Orthopnea is like, it gets worsened when you're in a supine positions, okay? When you're sleeping or if you're lying flat, this gets worsened because the venous return increases from the GI and then all the lower extremities part of the body, and the PND, proximal nocturnal dyspnea. You also see that because you're waking up like two to three times in night to actually catch a breath, okay? You also see advanced cardiac failure, you do sense stroke breathing, which I talked about. There's apnea, and there's an increase in a little bit stroke volume, and it goes up, and then and also it comes down, and there's apnea again. You also see like dry cough. You see hemoptysis when there's a rupture in the end-goes bronchial vein. You see that. You see the crackles, popping crackles open, which is the rails. You're going to see that too, right? Now, not only that, one thing you could see is that if I'm talking about the hemosiderin, if you the heart failure cells, which are the macrophages, macrophage has the hemosiderin laden macrophages, and those are called heart failure. So you get to see that because in the alveoli, the dust cells, the macrophage comes and try to destroy those, clean the debris there. Okay. Now, these are some of the conditions that you get to see that when it comes to the left heart failures. Okay. When I'm talking about lungs now. Now, this is all resulted because of left backward failure. But what about the left forward failure? Because there's a less cardiac output go. When there's a less cardiac output, remember, your GI is receiving less cardiac output, your kidney is receiving less cardiac output, your skeletal muscle is receiving less cardiac output, your skin is receiving less cardiac output, right? So because of if there's a less cardiac output, what happens is that means your perfusion pressures to the systems are going to be very, very low, right? Your brain is going to be less perfused, right? When your brain is going to be less perfused, there are going to be alterations in your mental status. So you feel a lot of confusions on this too, okay? Confusion. There is one thing that you get to see this with the brain, and then like skeletal muscles, like when there's less perfused, what happens? The skeletal muscles feels weak and fatigued. That's a common thing with the kidney. The urinary output during, like let's say during the daytime, what happens is that, or standing position, what happens is that your urine output will decrease because there's a less cardiac output, right? If there's less cardiac output, urine output is going to decrease, right? But the important thing is that urine output increases if you're in a supine position because the venous return increases, there will be a little more perfusion coming to the kidney. So your urine output does increases when there is when you are actually lying flat. That's something that I had to let you know, guys. Now, there's some of the thing that I also have to tell you guys is that all this this is because of the left heart failure, right? Now, before even this happened, right, what is also playing a role is that try to compensate or try to fix the system. Our physiological response also playing a role when we haven't talked about that yet. Whenever there's a cardiac failure response, whenever this symptom happens, look, what is happening here is that our heart, okay, our systems if you remember from your brain, from your medulla, we have those cardiac accelerator centers, right? Cardiac accelerator centers or cardiac those vasomotor centers, right? What are these guys are doing? The cardiac accelerator centers is going to try to do what? You're trying to do increase heart rate, okay? Try to contract by giving catecholamines, like releasing epinephrine and norepinephrine to this receptors on your heart cells, right? Or when you're there with the receptor, you're trying to increase with the beta one, right? So you're trying to increase the heart rate, or you're trying to increase the contractile tissue. That's what these guys are trying to do. So increase so that way increase the cardiac output, right? So they are going to do that. Does get activated, and sympathetic nervous system does increase contractility and does increase heart rate, right? And they also activate the vasomotor center, right? And with the vasomotor center, what's going to happen? It's going to do constrictions at venous site, so that way increase in venous tissue, and it also going to constrict at your arterial side, so that way it maintain your TPR. Because remember, we have to maintain this mean arterial pressure, because mean arterial pressure is a perfusion pressures for a system of circulation, right? And then So that's what they are doing too. And then in long term, what is also happening is that your renin gets activated, right? The renin pathway, renin angiotensinogen aldosterone pathway also get activated, and that is whole to actually increase your blood volumes, or because to maintain the cardiac output. So when they get activated, there's angiotensinogen 2, which is very important in the kidney, right? And then also because of that, what is going to happen is that there will be increase in, like, let's say volume. There will be increase in the volume, but because there is increase of volume and there is a sodium and concentrate will get reabsorbed in water, and we have talked about this in the renin pathway, right? And when that happens, what happens is that whenever the volume overload, or what's gonna happen is that this atrial, where is this atrial cells, atrial cells, or this the ventricle, they will release this hormones called ANP and then BNP. Okay, atrial natriuretic peptides and then BNP. And remember, atria has a very good importance. What atria does is that it goes to kidney, and this is afferent arteriole, let's say, and let's make this as, hold on, because kidney is a little different than this one. Kidney is literally, they have afferent arterioles, and then let's make this as efferent, this is glomerular, and there's efferent arterioles, right? So in the arteriole, what it does with the ANP, it does vasodilation here, and is in efferent artery it does constriction, so that it increase in glomerular filtration rate. So that means that we can remove all this, so there is more diuresis can occur, so that we can remove this fluid. It does that, but even with that too, your sympathetic nervous systems, they overtakes these hormones, okay? Hormones, and then same thing, the BNP has also the same role, okay? But one of the most important of the concept of the BNP is that in your lab, with the cardiac failure, you're always going to see like high level of BNP, okay? You're always going to see the high level of BNP, and that has to do with the consumptions of retentions of the blood volumes on the ventricles, okay? And then not only that, like your ADH get activated, arginine vasopressins or antidiuretic hormones also get activated, right? And they go to like your brain, especially from like your hypothalamus, right? They will go to deep nuclei, and they will stimulate the thrust centers, and then you'll be thirsty, and there'll be increase in water intake, and they also go to the kidney, the collecting tubules of the kidneys, and then they'll with the receptor, what they try to do, they'll try to reabsorb the water too, so that way you have increase in circulatory volumes. These guys also play a role into ADS2, and we have to talk about. But these are the physiological response that our body try to compensate. There's a compensation mechanism to actually to increase your cardiac output. But even with that too, obviously when the failing heart, it's not going to increase. And because of the volume overload, that there will be volume overload and all that stuff, that could result into like peripheral edema. Like, you'll have edemas into it because you're retaining this volume of the fluids actually in your body. And then we want that, right? But that's what we're trying to do. But then the problem is that there is a volume, but it's just that they're distributed in a wrong places, okay? Because they're not in the correct places, they're because of that result into like edema, okay? These are called they're going to be peripheral edemas, and usually like these are like a pitting edema or so. And then as you move, it can also like change, the fluid can actually sift around, and if the fluid can sift around as you move or be based on the gravity, we call them as a dependable edema too, right? Now, this is the pathophysiology of left heart failures right now, right? Now, this left heart failure, obviously we talked about what's going to happen to because, and also one of the things, just letting you know, like with the GI too, like whenever there's less perfuse, you don't want to eat, okay, you lose appetite, and then you also like you lost a body weight, and that's called cachexia, that's what they call, right? And then so obviously you feel weak and fatigues because there's less perfuse, and then obviously your hands are going to be very, very cold, okay, on the lower extremities and upper extremities of part of the body with the system circulation. There will be a peripheral edemas, and then obviously because of back pressure, what's going to happen is that there's a pulmonary congestion, which we talked about. This is going to give you the orthopnea, it's going to give all this orthopnea, fatigue. We talked about this, right? And also remember, guys, because with this one, because of sympathetic nervous system, these guys will get a tachycardia because sympathetic is always like trying to increase the heart rate, so that way to maintain the cardiac output, right? And you do get the pulmonary rails. as I said, you can get this one. You can get if you're talking about systolic dysfunctions, you get the astrogala. But if you're talking about the, let's say, diastolic dysfunction, then you get the aspergala. Because remember, if left ventricle is hypertrophy, and then if in a higher pressure, if the atria has to contract to propel the blood into the ventricle, then that would able to put an S4 sound. Okay, but there's volume overfilled, and you're just pushing, and then there's a passive fill the volume, which usually happens in systolic, then you would get the S3 sound, right? And you also use a loud P2 sound. Also, you'll hear on your clinical physical findings. Okay, now this left heart failures could result into, because there's a lot of this fluid accumulating, right? And this is going to cause fibrosis in here, right? This is going to be restrictive now. And what's going to happen if it's restrictive? Then this pulmonary artery would not able to bring the blood into it. So this pulmonary, there's a lot of resistance to bring the blood into it. So now this can cause the pulmonary artery become pulmonary artery would not able to drain the blood into it. So this one can go into pulmonary hypertension. And from the pulmonary, if there's pulmonary hypertension, a lot of resistance over time, your right ventricle from the pulmonary valve would not able to push the blood into it. So there's a back pressure will happen, right? So there's the ventricle what happens, a lot of pressure on the ventricle. So now the ventricle will go to hypertrophy. Then from the ventricles, if there's the hypertension ventricles, the atria would not able to propel the blood from here. Then there's right atrial pressure will go up. If the right atrial pressure will go up, when the atria contracts, your jugular venous pressure will go up, right? And then if the jugular venous pressure goes up, look, inferior vena cava is actually bring the blood into it, and then all the blood will do a backflow happens, and that would be a right heart failure now, right? So your left heart failure could cause also right heart failure. That's what I want to let you know. But right heart failure itself, we'll talk in a different class, okay? But right now, but we're just focusing more into this one, just the left heart failures, okay? And this is very, very important because of pulmonary congestions, and then because of fluid edema, it will compress the wall of the, as I said, excess fluid in the interstitial, compress the wall of the bronchioles and alveoli, increasing the resistance to airflow as well, right? Requiring the greater effort of the respirations. So that's why you have to do labored breathing, because your lungs becomes like frail or big and it's congested lungs becomes frail and big. And actually, if you look at an X-ray too, you should be able to see it's very clear, sort of like your pulmonary lungs. Okay, so quickly, if I have to review quickly, some of the things that I wanted to let you know, guys, is that this one try to cover both systolic dysfunctions and diastolic dysfunction. Remember, one of the thing with the diastolic dysfunction is less end-diastolic volume, okay, and high end-diastolic pressure. But systolic, both end-diastolic volume and end-diastolic pressures are higher in both the cases. Ejection fractions, when it comes about the systolic, it's low than 55%, which is abnormal. But in the diastolic dysfunction, ejection fraction could be like Okay. Diastolic feeling we talk about, it's more that your feeling time has been compromised. The ventricle is not relaxed. So if his ventricle is not relaxed because of ventricle hypertrophy or because ventricle is less compliant, because of that, the feeling is not happening properly. So there will be low end-diastolic volume. So because of that, there will be a low cardiac output when it comes to diastolic dysfunction, right? And we talk about restrictive diseases. That is a case of diastolic dysfunction because it's not going to be able to be compliant. Okay, it's less compliant. I talked about that kind of stuff, right? And then obviously we talked about how the acid sounds and aspirate sounds are produced too. Just letting you know, acid sound could be normal too if that's happening in exercise or even pregnancy women or younger children. So you have to be very, very clear whether it's caused by cardiac failures or not. Talk about the pulmonary congestions, because a lot of edema, fluid that is built up in interstitium, right? And then these guys can actually rupture the bronchial veins, also compromise the alveoli, right? So because of that, they will also compromise the gas exchange happening there too because of pulmonary edema, right? Now, obviously with that pulmonary edema, a lot of fluid accumulated, the lungs become very, very heavy, and then becomes, and then it becomes unpleasant breathing, right? And that's called dyspnea. And then whenever you're supine position, this people of venous return increases. Look from the lower extremities, probably intravascular compartment. So what happens is that everything levels off, and these guys will have difficulty. Like labored breathing, so but sitting upright position, that makes it better. That's called orthopnea. And we also talk about PND, which is proximal nocturnal dyspnea, which basically means that you're getting up to catch a breath. You can see a signs of like shin stroke rhythm. We talked about that too. And then obviously that could lead to pulmonary hypertension. We also talk about hemoptosis, like coughing of the blood because of the rupture and engorged vein too, right? We also talk about the alveolar dust cells or the heart failing cells. You could also see that. And we also talk about what are the etiology or what are the causes of the left ventricular failures, okay? I think that's it for now. I hope like I made it very clear, guys. This is very, very important concept that we need to understand in very detail about like how, what are the causes of left heart failures and what are the symptoms and signs and symptoms. You see that during your physical examinations. And also remember, guys, I even told you about the cardiac wheezing. Make sure that there is a wheezing. Just because there's a wheezing doesn't mean that it's produced by asthma. So you have to, or other way around. It could be because of cardiac failures. You have to be very, very clear about whether it's caused by the heart failures or it's caused by the asthma. And we also talk about the level of the BNP level. It's always going to be higher when it comes about the cardiac failures, left cardiac failure or right cardiac failure, it'll be high. And we also talk about the edema. And then for now, I think we'll end the class here right now. All right. Thank you, guys.